welcome back. This is video 3 for the endocrine system, chapter 18, AMP2, Panola College. So in this particular video, we're going to go over, a number of different endocrine glands. We're going to start up at the hypothalamus and make our way down. And we'll just start with the chief kind of president of the endocrine organs, endocrine glands, and then we will conclude with the gonads, if I'm not mistaken. All right. So as you all know, I know you've been seeing the superhero characters in my lectures, so that's just kind of characteristic of how I structure them with the bubbles. But the way that this is going to work is that we will cover an organ. We will go over the anatomy, basic anatomy and physiology of that organ, and then we will go through diseases and disorders, so pathology associated with that organ. So we will do, for instance, pituitary anatomy, then we'll do pituitary physiology, then we'll do pituitary pathology, and we'll do that for every single endocrine organ. Okay. All right, so I just want to check out this quick video clip, and then we will get started on the hypothalamus. So here we go.
All V needs to do is keep his word.
Wanted to start off with that clip because indeed all the pieces do matter. All of these endocrine glands and organs do have a vital role to play in the regulation of homeostasis and just general upkeep, regarding the body. So like I said, we're going to start off with the hypothalamus, and then we will work our way down. So you can see here that the hypothalamus is not actually a physical organ, but rather a space in the brain. If you look here, get my pen. So this area right here is the thalamus, okay? And literally the hypothalamus is inferior to the thalamus, okay? So this area right here is the hypothalamus, and this is the area that is going to secrete a number of releasing and inhibiting hormones, which we will go through, okay? So if we revisit our hierarchy model using Panola College administrators, the hypothalamus would be Dr. Pace, the president of Panola College. And as we said before, the hypothalamus is a very small gland buried deep in the brain below the thalamus. Okay, so the name literally describes where it is. The job of the hypothalamus is to collect information from each body system. And it will also integrate the responses of the nervous and endocrine systems to maintain homeostasis. So really the hypothalamus is the the ultimate administrator, collecting all types of information from the body systems and just integrating responses so that all of the systems can work together in an effective and efficient manner. Okay. It will play an important role in maintaining uh, metabolism, heart rate, blood pressure, also blood composition, sleep regulation, thirst, nutrient intake, energy level, body temperature, and emotion. So the hypothalamus wears a lot of hats when it comes to regulation in the human body. Remember that the hypothalamus is part of the nervous system. So this is part of that, nervous system, endocrine system integration and collaboration. Despite this, it is also part of the endocrine system as it secretes both hypothalamic releasing and non-releasing hormones. Remember that a hypothalamic non-releasing hormone can also be known as a hypothalamic inhibiting hormone. Okay. These hormones will function to either stimulate in the case of a releasing hormone or inhibit in the case of a non-releasing hormone, the pituitary gland. So once again, coming back to this example here, okay, Dr. Pace being the president of Panola College, will direct, instruction or orders to one of her vice presidents, who is pictured here, Dr. Adams, and so all of the activities that take place really begin with her and then trickle down. Okay, so in the same way, activity in the endocrine system will begin with the hypothalamus and then trickle down. Okay. So the hormones are released into portal circulation, which connects the hypothalamus to the anterior pituitary. Okay. And the pituitary gland will then in turn function to either stimulate or inhibit the target endocrine organ. Okay. The hypothalamus will also produce two specific hormones, and those are antidiuretic hormone, again otherwise known as ADH, and oxytocin, otherwise known as OXT. These hormones are carried to the posterior pituitary gland via neurosecretory cells for storage. Okay, so when we get to the pituitary gland, we're going to do that in this particular video. One of the things that we will talk about is how the pituitary gland is made up of two lobes. We have the anterior pituitary, which is right here, and then we have the posterior pituitary, which is right here. Okay, the anterior pituitary is going to manufacture six hormones that we will talk about. But the posterior pituitary, and this is a very small but very important detail. Okay, so the anterior pituitary produces 6 hormones, but the posterior pituitary does not produce hormones at all. The posterior pituitary serves to only store hormones. Okay, so what happens is these two hormones, ADH and oxytocin, will be produced by the hypothalamus up here, and once they are produced by the hypothalamus, they will then make their way down this way through this neurosecretory channel or network to the posterior pituitary. Well, they will then be stored. Okay, and once they are ready to be used, the posterior pituitary will then release those into portal circulation. Okay, so that's the point that I wanted to highlight down here, is that ADH and oxytocin are produced by the hypothalamus, but they are released from the posterior pituitary. The posterior pituitary does not produce ADH or oxytocin. It is only a storage vessel. It is not a production vessel. So it differs from the anterior pituitary in that particular regard. So you can see over here in this image, you see the hypothalamus up here. ADH and oxytocin will be produced in these two areas here, and then they will make their way down to the posterior pituitary, which is here, where they are released into venous circulation or venous drainage. ADH will act at the kidney tubules. We'll talk more about what ADH does a little bit later on. And then oxytocin will act in two places, that is the mammary glands and the uterine muscles. So we'll talk more about that as well. So remember previously we talked about three arms of endocrine gland regulation. And those three arms, if you recall, were neural control, hormonal control, and humoral control. Okay? So the hypothalamus is going to coordinate those three arms of control in the endocrine system. So let me just get my pen again, and we're going to do this in our different colors. So number one, oh wait, that's the highlighter, sorry. And we're going to get the red pen. Okay, so number one, secretion and release of hormones from the anterior pituitary, secretion and release of hormones from the posterior pituitary, and secretion and release of catecholamines from the adrenal medulla. Okay, so I made a small error there. So the three arms of control here are not the three arms of regulation from before for the endocrine system. What we're talking about here, if you look up here at the hypothalamus, okay, you can see over here we have control of the sympathetic output to the adrenal medulla. Which is taking place over here. Okay, remember the adrenal medulla is that inner portion of the adrenal gland. Okay, and from the adrenal gland, we get the release of epinephrine and norepinephrine from the adrenal medulla. Okay, so that's your first arm of control in the endocrine system, and that is what we have detailed right here. Okay, the second one, which we'll do, let's do the anterior pituitary. Secretion of regulatory hormones to control activity of the anterior pituitary. So we have the hypothalamus releasing those hypothalamic releasing or hypothalamic non-releasing hormones to the anterior pituitary. And then the anterior pituitary will then in turn secrete hormones that will control endocrine organs. So that's this second arm of control right here. Okay. So we come down from the hypothalamus, releasing or non-releasing hormone, and then the anterior pituitary will release one of 6 hormones. Okay? So that's that second arm of control. And our third arm of control, which we'll do in green, production of ADH and oxytocin in these neurosecretory areas. ADH and oxytocin will then make their way down to the posterior pituitary. Remember, once again, that the posterior pituitary is a storage vessel only. It does not produce anything. Okay? And when the time is right, we get release of ADH and oxytocin from the posterior pituitary. And that is what we see here. Okay? So 3 different arms of control for the endocrine system that the hypothalamus will coordinate. Okay? All right, so we talked about the hypothalamus and its role in initiating essentially endocrine function. And now we are moving down to the second in command, which is the pituitary gland. Okay? So the pituitary gland is a pea-sized gland with 2 lobes, anterior and posterior. It's located in the depression of the sphenoid bone of the skull and suspended from the underside of the hypothalamus by a short stalk called the infundibulum. Okay? This is the infundibulum right here. Okay? So that's that short stalk that will suspend the two lobes of the pituitary. Hormones secreted by the pituitary gland can function in one of 2 ways. Okay? So a hormone secreted by the pituitary gland can either act, number 1, directly on a target tissue to cause a metabolic response. We call these particular hormones non-tropic hormones. The other type of way a hormone can function is to stimulate other endocrine glands, which are the department heads, okay, to release their own hormones. We call these tropic hormones. So just to kind of recap here, okay, if a hormone released by the anterior pituitary acts directly on tissue, okay, so it's not acting on an endocrine gland, it's acting directly on a particular tissue, that hormone is classified as non-tropic. If the hormone stimulates another endocrine gland, okay, then that hormone is classified as tropic. Okay, so these are 2 terms that you need to get a handle on and know the difference between them. Okay, tropic hormones act on other endocrine glands. Non-tropic hormones act on tissues. And here we have the 6 different hormones secreted by the anterior pituitary. Okay? So growth hormone, prolactin, ACTH, TSH, FSH, and LH. So growth hormone, prolactin, adrenocorticotropin hormone, thyroid stimulating hormone, follicle stimulating hormone, and luteinizing hormone. Okay? Need to know these 6 hormones cold, ladies and gentlemen. Okay? Need to be able to list these at the drop of a hat. Should be able to list these 6 anterior pituitary hormones. Okay? Now, of these 6, these 4 here, ACTH, TSH, FSH, and LH, are going to be tropic. Okay? So these will act on other endocrine organs. Okay? The other 2, growth hormone and prolactin, are going to be non-tropic. So they will act directly on target tissues. Okay? And specifically, FSH and LH, these two tropic hormones, are classified as gonadotropic hormones, meaning that they are tropic hormones that act on the gonads. Okay? And they're going to do different things in males and females. So these are your 6 anterior pituitary hormones: ACTH, TSH, FSH, and LH are going to be your tropic hormones. FSH and LH are your gonadotropic hormones, and then GH and prolactin, are your non-tropic hormones. Okay. So what we're going to do now is we're going to go through each one of these hormones and talk a little bit about what they all do. Okay. So let's start with the 4 tropic hormones. Okay. So let's start with adrenocorticotropin hormone, otherwise known as ACTH. And ACTH is going to act on the adrenal cortex of the adrenal gland to stimulate the release of steroid hormones. Okay? So remember, the adrenal cortex is this outer, I'm just going to highlight here and here. And then I'm going to get a little highlighter. I'm just going to shade in all of this. So all of this here, this is all adrenal cortex. That pink inner part, that's the adrenal medulla. So ACTH is only going to act on this outer part of the adrenal gland, will not act on that inner part of the adrenal gland. Okay? And again, that will stimulate the release of steroid hormones, and we will talk more about those hormones a little bit later on. But there are 3 in particular, 3 steroid hormones that will come from the adrenal cortex. Okay? And so you see that over here. Okay? Just want to point it out in the image. ACTH coming from the anterior pituitary, acting on the adrenal cortex. Okay? Thyroid stimulating hormone, which is here, is going to act on the thyroid to stimulate the release of 2 thyroid hormones. That is T3 and T4. When we get to the thyroid, we will talk more about the differences between these 2 thyroid hormones. But this is your thyroid hormone over here. Okay. And that is where TSH from the anterior pituitary will act. Okay. And then we have our 2 gonadotropic hormones, follicle stimulating hormone, FSH, which will stimulate the production of estrogen and oocytes in females and sperm in males. Okay, so FSH is going to give you your estrogen and eggs in females and then sperm in males. Luteinizing hormone, your other gonadotropic hormone, on the other hand, will stimulate the production of progesterone, estrogen in eggs in females, and testosterone in males. Okay, so very important to get a handle on what these 2 gonadotropic hormones are responsible for producing. And you can see down over here, LH and FSH acting on the testes of the male and the ovaries of the female. Okay. And that's another thing I wanted to point out here. is that LH and FSH will act in both males and females. Okay, so one hormone is not exclusive to one gender. Both genders make both, and both hormones act on both gonads. Okay. So these are our 4 tropic hormones. Notice once again, let's start over here with ACTH. It's acting on the adrenal gland. The adrenal gland is an endocrine gland, therefore it is tropic. TSH, acting on the thyroid gland. Thyroid gland is an endocrine gland, therefore TSH is tropic. FSH and LH, acting on the 2 gonads, which are both endocrine glands, therefore FSH and LH are tropic, specifically gonadotropic. All right. Now, when it comes to the non-tropic hormones, that is growth hormone and prolactin, growth hormone, which is depicted over here, is going to act in a number of different areas. Okay? So it will stimulate the growth and development of muscles, cartilage, and long bones of the body. So this is going to be what's responsible for general growth, in humans as we age. It will also break down fats for use as a fuel source, and will also convert fats and proteins into glucose. When we get to talking about glucose metabolism and how glucose levels are maintained within the blood, we will talk about growth hormone's role in that process. Okay. All right. All right. I think there's something. Oh, this process right here, number 3, the conversion of fats and proteins into glucose. That is something that we call gluconeogenesis. Okay, so gluconeogenesis is the creation of glucose from fats and proteins. And what I always like to do when we get words like this is to break these words down. Okay, so we have gluco, we have neo, and we have genesis. Gluco, of course, means glucose. Okay, neo, you're a fan of the Matrix series, okay? Neo means new. Okay, and then Genesis means beginning or creation. So the term gluconeogenesis quite literally means new creation of glucose, okay, from fats and proteins. All right. And that will actually happen in the liver. That's why the liver is pictured over here. Okay, that's where gluconeogenesis takes place. Okay. All right, so that's growth hormone. Notice it's acting on the liver, acts on fat, acts on muscle, acts on bone. So these are not endocrine organs. Okay, so that makes it a non-tropic hormone. Prolactin is going to act in 2 areas. It's going to stimulate the growth of mammary glands, otherwise known as the breast, pictured over here. And it will also stimulate milk production in a nursing mother. Okay. Now, I want to make sure that this is clear because students get this confused all of the time, right? So prolactin is responsible for milk production in the breast in a nursing mother, okay? Oxytocin, which is going to be another hormone that we're going to talk about, is going to be responsible for milk ejection from the breast in a nursing mother. Okay, so two different hormones. They both are responsible. Are both involved with breast milk, but they do two different things. Okay, so prolactin is going to be milk production. Oxytocin is going to be milk ejection. Okay, so please do not get those two functions confused. Mammary gland is not an endocrine gland, it's actually an exocrine gland, and therefore prolactin is a non-tropic hormone. Okay, so let's talk about this system here. It's called the hypophyseal portal system. Okay, and the hypophyseal portal system is essentially the system that allows hormones to get from the hypothalamus down to the anterior pituitary. Okay, so look over here. This is the anterior pituitary. I'm just going to abbreviate that to AP. This is your posterior pituitary. I'm going to abbreviate that to PP. Okay? Excuse me. So, what we have, this is the superior hypophyseal artery. Okay? And that's going to deliver blood to a capillary network in the upper infundibulum. Remember, the infundibulum is that short stalk right in here. Okay, that's going to connect the hypothalamus to the pituitary. So that superior hypophyseal artery will deliver blood to this capillary network here. We have this artery down here. Oh, I'm sorry. We're going to go over here first. So superior hypophyseal artery, infundibulum. And then if you look over here, we have all of these blue vessels, okay? So this is a venous system. And the portal vessels, okay, which are pictured over here, will deliver blood containing regulatory hormones to the capillary network in the anterior lobe of the pituitary, which is over here, okay? Now, before we go on, I want you guys to notice something about this particular system. Notice that the vessels here in the infundibulum, they are continuous with the vessels in the anterior pituitary. But the vessel system in the posterior pituitary is completely separate. Okay, so that is key to understanding how the anterior and posterior pituitary lobes work. All right, so that superior hypophyseal artery delivers blood to the infundibulum, and then that blood will then travel down to the anterior pituitary. Okay. All right. Okay. Now, if you look over here, we have an artery entering the posterior pituitary. That's your inferior hypophyseal artery that will deliver blood to the posterior lobe of the pituitary. And then we have these three vessels here, which are called hypophyseal veins, that will carry blood containing the pituitary hormones to the cardiovascular system for delivery to the rest of the body. Okay? So if you look over here, these two vessels here will deliver the 6 anterior pituitary hormones that we just talked about. Okay, so ACTH, TSH, LH, FSH, growth hormone, and prolactin. Okay, so those 6 hormones will be delivered through these 2 vessels here. Okay, so here and here. This one hypophyseal vein right here will deliver the 2 posterior pituitary hormones, which we will talk about in just a moment, which are ADH and oxytocin. Okay? But that's how the hypophyseal portal system works in getting hormones out to the body. Also, notice up here, you have those neurosecretory cells, okay, which will produce oxytocin and ADH, and then they will flow down this system here and then empty into this circulatory system here, okay? So important to realize that the vessel system where the anterior pituitary and posterior pituitary are separate. Okay? All right. Okay, posterior pituitary, as we said before, it is actually an extension of the hypothalamus. And again, it does not produce hormones, but it stores 2 hormones, that is ADH and oxytocin. Okay? Because it does not produce its own hormones, the posterior pituitary is not a true endocrine gland. Okay? And so it is sometimes referred to as a pseudo-endocrine gland. Secretion of hormones from the posterior pituitary is the result of nervous stimulation of the hypothalamus. Okay? So those 3 systems that we talked about, neural control, hormonal control, and humoral control, okay? We're talking neural control here, okay? Because this is nervous stimulation. So there is no, hypothalamic releasing hormone for ADH or oxytocin, okay? That system doesn't apply here. It would be the neural control that would apply here. Okay. Okay, so we have 2 areas of the hypothalamus, specifically that produce ADH and oxytocin. The paraventricular nucleus, which is this green portion right here, will produce oxytocin, and the supraoptic nucleus, which is this yellow part right here, will produce ADH. Okay. As you can see over here, hypothalamus synthesizes these 2 hormones. Posterior pituitary will store and release those 2 hormones. Okay. So again, hypothalamus produces those 2 hormones, posterior pituitary stores and secretes them. All right, so let's talk about the 2 posterior pituitary hormones. Let's start with ADH, or antidiuretic hormone. To understand what ADH, or antidiuretic hormone, does, let us break down the word antidiuretic hormone. Okay? So, of course, we know that anti is going to mean against. Okay? Diuretic, okay, anytime you see the word diuretic, that is going to mean, and for lack of a better technical term, pee. Okay? So if you ever heard of medications that are diuretics, okay, those will cause patients to actually urinate. And the purpose of that in getting them to urinate is that they're going to be eliminating body volume. And by eliminating body volume, you will decrease blood pressure. So that's how diuretic medications work. Okay. Now, antidiuretic hormone. Anti means against, diuretic means pee. So antidiuretic hormone is a hormone that will prevent peeing. Okay? So anti against, diuretic pee. The hormone, antidiuretic hormone, will prevent peeing, essentially. Okay? So just keep that in mind. And that's what we see over here. Decreases urine output. Okay? So that's its first main function, is to decrease urine output. And when you decrease urine output, you are retaining volume within your body. Okay? And as you retain that volume, that body fluid volume, that's going to have another effect when it comes to blood pressure, which we'll talk about in number 2. But ADH will stimulate the kidneys to increase water reabsorption, thereby decreasing urine output. Okay, this is going to increase body fluid volume. And its release is mediated by humoral control, that is, decrease plasma volume. Okay, so we talked about that arm of the endocrine system earlier, and how it essentially just monitors different levels of substances in the blood. Okay, in this particular instance, it's monitoring the plasma volume itself. Okay. All right. So, first major function for ADH is to decrease urine output, thereby increasing body fluid volume. As you increase your body fluid volume, you are going to increase your blood pressure. So number 1 actually causes number 2. Okay. But specifically, ADH will also narrow the arteries in the body, causing increased resistance to blood flow. And like we said earlier, the increased body fluid volume will also lead to increased blood pressure. And these two things collectively will lead to more blood flowing through smaller vessels. And this will lead to an increase in blood pressure. Okay. If you think about a garden hose, you've ever played with a garden hose in the summer, okay, you turn on the water and you have the water coming through the hose, okay, you pressure your thumb or your finger down on the hose and the water is going to come out of the hose with greater pressure, okay. So you pressing your thumb or your finger down on the hose represents narrowing of arteries in the body. So as those arteries narrow, blood pressure is going to increase because of increased resistance, okay? And because of this increased body fluid volume, you have more volume going through smaller vessels. So that's what's going to cause that increased blood pressure, okay? So the bottom line here is that you are increasing blood pressure. That's the ultimate result of all of this. Okay. Oxytocin, on the other hand, that's your other posterior pituitary hormone. And this is going to be produced by pregnant women uh, during labor. And it will stay in their bodies until they have finished nursing their child. Oxytocin will stimulate the muscles of the uterus to contract. So this is what is going to lead to the onset of labor in the pregnant woman. Okay. Oxytocin release is also promoted by the sucking mechanism of the nursing infant, which promotes the milk ejection or letdown reflex. So this is what I was talking about before when I said that oxytocin is going to be responsible for breast milk release or breast milk ejection. This is also known as the letdown reflex. Okay. So important to have those two functions straight. Oxytocin is breast milk ejection or release. Prolactin is breast milk production. Okay. Pitocin is a synthetic IV form of oxytocin, which is given to induce or speed up the delivery of a baby. Okay. So if you actually don't want to wait for the onset of labor, you can actually give a pregnant woman a synthetic form of oxytocin called pitocin, and that will cause the onset of labor. Okay. There are multiple indications for labor induction, but we're not going to get into all that right now. All right. I just want to include this slide here just to talk about oxytocin and its role in breastfeeding. Okay, so one of the things that healthcare professionals will talk about when a new mom has given birth to a baby is they will actually ask the question of whether or not the mother in question is going to breastfeed or bottle feed. Okay, and the thing to kind of keep in mind here is that it is, well, I won't say it is best, but because of the role of oxytocin in breastfeeding, if you intend to breastfeed, it is best to actually breastfeed exclusively. And the reason for that is because we talked before about how oxytocin will cause milk to be released from the breast. Okay? As milk is released from the breast, that's going to give incentive, or it's going to inspire or make the baby more apt to suck, to engage in that sucking mechanism. The sucking mechanism will then promote the release of more oxytocin. Okay, so if we go back here, oxytocin release is also promoted by the sucking mechanism of the nursing infant. But oxytocin will also cause that milk ejection letdown reflex. Okay, so because of this, we get this cycle going on. Okay, oxytocin will promote breast milk release, and then breast milk release will then cause the infant to want to suck more. That sucking will promote the release of more oxytocin. Okay, so this is a cycle that occurs in the breastfeeding mom. If you are breastfeeding, okay, and then you decide to bottle feed, you are essentially knocking out this cycle. Or maybe not knocking it out, but at the very least, you're going to be interrupting it. Okay. And if this cycle is interrupted, it's going to make it less efficient and less effective. Okay. So this is why, if you're going to breastfeed, it's better to breastfeed exclusively. If you want to bottle feed, it's better to bottle feed exclusively. If you breastfeed and then go to bottle feeding, that's going to make the breastfeeding less effective. So that's why they say, if you're going to breastfeed, just do that exclusively. Okay. But that is an example. That's a kind of a practical application of physiology here with oxytocin. I always like to point out when it comes to oxytocin, so it helps you remember, the functions of oxytocin. Okay. All right. Okay. This is another very important slide. Okay, because here we are talking about the releasing hormones from the hypothalamus and what that will cause in the pituitary. Okay, so if you look up here, hypothalamus synthesizes and releases all of these hormones. Okay, so these first 1, 2, 3, 4, 5 hormones are hypothalamic releasing hormones. So these will promote the release of hormones from the pituitary. These 2 hormones here are your hypothalamic non-releasing hormones, otherwise known as inhibiting hormones. There's only 2 that you need to be familiar with. Okay. So essentially what happens is, for example, the hypothalamus will release thyrotropin-releasing hormone, TRH, and then TRH will then travel down to the anterior pituitary and cause the release of TSH. So TRH causes the release of TSH. PRH, which is prolactin-releasing hormone, will cause the release of prolactin. GnRH, known as gonadotropin-releasing hormone, will cause the release of FSH and LH. Okay, so this particular hormone from the hypothalamus will do 2 distinct hormones in the pituitary. CRH, which is corticotropin-releasing hormone, will do ACTH, and then GRH will do GH. Okay. Remember that, what was I going to say? Actually, was it ADH? One second. There's a slide. Actually, never mind. All right. Your 2 inhibiting hormones, prolactin inhibiting hormone, PIH, will cause, so if this is released from the hypothalamus and travels to the pituitary, it will actually cause prolactin to not be released from the pituitary. And if GIH, or growth hormone inhibiting hormone, is released, that will cause growth hormone to not be released. Okay, so you wanna know these releasing and inhibiting hormones very well, and know what releasing hormone goes with what pituitary hormone. Okay. All right. So if we look here at the tissue section of the anterior and posterior pituitary, The anterior pituitary is going to be glandular in nature. We already talked about these 6 hormones over here that they will produce. Okay. And the posterior pituitary is going to be more nervous in nature because, as stated before, it is an extension of the hypothalamus, which is part of the nervous system. And so it is going to be nervous in nature, and it will secrete ADH and oxytocin. Remember that these 2 hormones over here are produced by the hypothalamus. These 6 hormones over here are produced by the anterior pituitary. Okay. All right, in between the anterior and posterior pituitary, we have the intermediate pituitary. And this is also called the pars intermedia. And this secretes 2 forms of melanocyte stimulating hormone, or MSH. Okay. And as the name suggests, MSH is going to stimulate melanocytes of the skin, increasing their production of melanin. Okay, so this is a hormonal pattern that we see here. Dopamine, which is a catecholamine, will inhibit the release of MSH. Okay. In humans, the pars intermedia is virtually non-functional, and circulating blood does not contain MSH, but we do have some exceptions. Okay. And those are as follows. So we have 4. So during fetal development, you'll have some activity of MSH. In very young children, you can have some production of MSH. Number 3 is the notable one, and that is what occurs in pregnant women. If you look over here, you see this half over here is the face of a pregnant woman, and this over here is a face of a non-pregnant woman. This increase in melanin production in the area of the face is called melasma, and that is actually referred to as the mask of pregnancy. And so it is not uncommon, for pregnant women to have a dark coloration in their face due to the increased melanin production. Okay. Of course, you're not going to see that in darker skinned individuals, but it occurs nonetheless. Okay, so that's melasma, or the mask of pregnancy. The 4th exception occurs during the course of some diseases, which we'll actually talk about a little bit later. Okay, so those are your 4 exceptions to that rule about MSH not being present in circulating blood. Okay, a little bit more on growth hormone. Okay, so what I'm going to do, you do have this image in your notes, but I'm actually going to go to this slide, and this slide will actually explain what's going on this slide. Okay. So the release of growth hormone, regulated by the hormonal stimulation by the release of growth hormone, releasing hormone from the hypothalamus. So GRH will come from the hypothalamus, stimulate the anterior pituitary to release GH. Okay. So what we see happening in 1, 2, and 3, which is right in here, is GRH entering venous circulation and being transported to the anterior pituitary. Okay, so I'm going to go back here real quick. You see that right there. Okay. Number 4, GRH will bind to the receptors in the somatotropic cells of the pituitary and stimulate the release of growth hormone into general circulation. Okay. So that is what is occurring right in here. GH being released, Okay, and that GH is going to travel to the liver, also enter general circulation and travel to other areas of the body. Okay. GH will stimulate the liver to release insulin-like growth factors. It will also, both GH and insulin growth factors will stimulate target cells, which are called effectors. Okay. And that is what we see happening. Number 6. Down in here. Okay. Notice that GH can actually feed back to the pituitary and the hypothalamus to shut this whole process down, to keep GH levels, at a reasonable level. Okay, so that's that homeostasis in effect once again. Okay. All right. So we have down here, so the top of this particular image is the bottom of this particular image. So this is essentially the continuation of what we had on that previous slide. Okay. So number 6 are your effectors. This is where GH is going to act. Okay. And it's going to act on bone, it'll act on muscle, cells in general, liver tissue, and adipose tissue. The net result of all of this activity is increased growth and nutrient release into the bloodstream. That's number 7. Okay. So what we have going on, general growth is going to occur because of GH's effect on bone and muscle, just cause them to increase in size and increase in number, along with all cells in general. So this will cause general growth. In the liver, we're going to get increased glycogenolysis and gluconeogenesis. Gluconeogenesis is that term that we talked about before. So if we look at this term, glycogenolysis, okay, so this is the lysis or breakdown of glycogen, okay, and when you break down glycogen, you get glucose, okay. When you have gluconeogenesis, you get new creation of glucose. So the effect of these two things is increased glucose production. Okay, that's what we see here. All right. Decreased glycogenesis, okay, is decreased levels of glycogen. So that's glyco, and then genesis. So this is the production of glycogen. Okay. So decreased production of glycogen means that you have increased levels of glucose. Okay. And then along with that, GH will also act on fat tissue. And this is going to cause increased lipolysis. Lipolysis is breakdown of fat. Now enter circulation. And then you're going to have decreased lipogenesis, so decreased creation of fat. Okay, so you have increased levels of glucose entering circulation, and you have increased levels of glycerol and fatty acids entering circulation. Okay, so that's what we mean by increased nutrient release in the bloodstream. We're talking specifically about glucose and fat there. Okay. Number 8, if we go back here, I believe. Yeah. So number 8, this is where we're talking about negative feedback. So growth hormone and insulin growth factors will feed back to inhibit the hypothalamus from releasing GRH. This also causes the hypothalamus to release growth hormone. Increased GH feedback will inhibit the pituitary from releasing a growth hormone inhibiting hormone. I'm sorry. Increased growth hormone feedback will inhibit the pituitary from releasing more growth hormone. Okay. Other stimuli, in addition to blood levels of growth hormone, influence the release of GRH from the hypothalamus. They include age, time of day, nutrient levels, and stress and exercise. Okay. So we'll talk more about these more on the next slide, and then that will bring us to the end of this particular video. All right. So, age. If you look over here at this graph, growth hormone levels will fluctuate with age. They actually decrease with age as we get older. Growth hormone levels will decrease. Okay, so this is what is responsible for, you see that rapid decrease in growth hormone from birth to around say maybe 12 to 15 years of age. Okay, so this is responsible for that rapid growth spurt that occurs in early life. But children and adolescents will experience the highest amounts of GH with progressive decreases in growth hormone as we age. Okay. Time of day. So in a normal sleep-wake cycle peak, GH levels will correspond to the early stages of a normal sleep-wake cycle, allowing the most growth to occur when we are sleeping. Okay. Another reason why sleep is so important. Nutrient levels, GH levels will increase to respond to, there's another typo here. That should be respond, not response. But GH levels increase to respond to increased amino acid levels, like after a high protein meal, or decreased glucose levels, say in hypoglycemia. Okay. And then stress and exercise, emotional, physical, and chemical stress will increase growth hormone release. Okay. So there's just some of the different things that can influence the levels of growth hormone in the body. All right, so we're going to stop here. When we come back for the next video, we're going to go through the diseases and disorders of the pituitary. And then we're going to head to our next endocrine organ, which is the thyroid. Okay. So that is where we are. Thank you so much.